we have Dr. Sahar Wertheimer. Fantastic new addition to our HRC family.
Thank you.
You have a patient who comes to you and she's been trying to get pregnant with her partner for 6 months to a year, never been pregnant before. We call her the patient with primary infertility. So how do you approach that patient with primary infertility?
First, start with a general history and try to understand if there's anything major that could be affecting her overall health or her fertility, and then try to really pinpoint some of the main areas of concern and see what I would add on to that.
How would you define it?
So the American Society of Reproductive Medicine would define it as 12 months of trying to conceive with unprotected intercourse in somebody who is under 35 years old, somebody who's over 35 years old, 6 months, and then they say at age 40 sooner.
Dr. Wertheimer, tell us a little bit about how you counsel patients to try to conceive. What's your recommendations for these patients?
3 steps. Step 1, you want to start tracking your cycles and understanding how many days from the first day of flow to the first day of flow of your next cycle, and then subtract 14 days because we know the luteal or the second half of the cycle is fixed. And then that gives you a predicted day of ovulation. Number 2, start using your ovulation predictor kit a couple days before your expected day of ovulation. And then you want to have intercourse the day it turns positive and the day after. Sperm that enters the reproductive tract after ovulation has occurred rarely leads to pregnancy.
Tell our audience about the kind of that window of fertilization for that egg.
Sperm can last in the reproductive tract for 3 to 5 days. The egg, from the surge of the ovulation hormone, LH, until it passes through the fallopian tube and out, is about 24 to 36 hours. If they have waited until ovulation has already occurred, then the egg might not be in a place of being able to be fertilized.
Dr. Wertheimer, let's talk about testing for the primary infertility patient, if you can elaborate a little bit.
I would start with basic evaluation. So I tell my patients you need 5 things to get pregnant, and I would try and test all of them. So you need eggs, although quality cannot be tested, quantity can, with some ovarian reserve testing. So FSH is a hormone that tells your brain how many follicles to bring to the front of the ovary. And if your brain has to work very hard because it has a lower reserve, then FSH will be elevated, and that's the indication of low reserve. We check AMH, which is a hormone given off from your smaller to middle-sized follicles and gives us an idea of your background reserve. And then other things we need to get pregnant include a functioning hormone to ovary axis. You need sperm to get pregnant, so I'll do a semen analysis. We want the tubes to be open, so we'll do an evaluation for the tubes. And then we want to make sure the uterine cavity and the uterus looks hospitable to an embryo. And so we'll do a transvaginal ultrasound, which gives us an idea also of reserve and then of the uterus shape. You cannot interpret a follicle stimulating hormone without an estrogen because they are variable throughout the month, and estrogen negatively inhibits FSH. So I will always get an estrogen with an FSH. If somebody's giving me a history, or if they're endorsing symptoms that make me suspicious of maybe some other pathology, irregular cycles, I might test other things as well. But I do on all patients like to test a thyroid, a vitamin D, and in a select group of patients also a hemoglobin A1C, because we know that those things can all affect fertility.
Tell me a little bit about recessive carrier testing for patients who show up, never been pregnant before. What's the positives of doing this test?
I am a very big proponent of expanded genetic carrier panels, which check, I think, over 400 recessive genes. I tell my patients that if you and your partner were to overlap for an autosomal recessive disease, Tay-Sachs, sickle cell, cystic fibrosis is a big one. Congenital adrenal hyperplasia is one where sometimes patients actually may opt out depending on the severity.
So if they both carry the gene, how do you counsel them?
I tell them that their fetus will have a 25% chance of not just carrying the disease, but being affected by it. It's informative because if they were to overlap, these days with the amazing science that we have, we can create probes specific to their mutation, test their embryos for that genetic disease, and not implant any embryo that has it.
How would you counsel a patient? They have a family history and to also test positive for BRCA. How would you counsel them for reproduction?
For their general health, we know that testing for BRCA is incredibly important because they can reduce their risk of breast and ovarian cancer with prophylactic surgeries and early screening. But for their reproductive goals, there is some data that shows that the BRCA carriers and other cancer gene carriers actually have a lower ovarian reserve. Fertility preservation might be something they want to focus on a little bit earlier. Maybe they want to test their embryos for that gene as well to know which ones are carriers.
How about Fragile X?
Fragile X I find very hard to counsel on, really takes time. A lot of times I like to send them to a genetic counselor for further counseling to see if it's something that we should be doing PGTM for or not.
how you counsel patients about having babies with autism.
Autism spectrum disorders have multiple genes involved. It's usually not just one single gene mutation. And actually, when I go through the expanded genetic carrier panel and what PGT-A is and what PGT-M is, PGT-A, A stands for aneuploidy, and in that test, we are looking for chromosomal number only. So is this embryo with a normal amount of chromosomes, 46? Or is it one that has extra copies of chromosomes or decreased copies of chromosomes? The other thing PGT-A can tell us, because it's telling us chromosomal number, can look at sex chromosomes and tell us if it's a boy or girl. PGT-M, M stands for mutation, single gene mutations. We can look for mutations that we know about ahead of time. So whether it's one that the couple overlaps for on expanded genetic carrier panel testing, or a single gene mutation like an autosomal dominant mutation that we've identified via history taking and appropriate genetic counseling tests.
How do you counsel them on prognosis?
If we're able to find that normal chromosomal embryo, that they have a very good chance of success with transfer. A normal college-age couple in their prime fertility trying to get pregnant is only getting pregnant about 30% of the time each month. With a normal chromosomal embryo, we're able to at least double that chance. And so it's not necessarily magic, but it is the magic of IVF.
Thank you, Dr. Wertheimer. We appreciate your time.
Me.
This is Dr. Sahar Wertheimer. Please come see her in West Los Angeles and Encino. Have a nice day. Thank you.
Thank you.